I made it through! The journey begins! Now, into the bloodstream.
Congratulations! Your drug survived the gut and made it through the liver's brutal first pass effect. It is finally in the systemic bloodstream. But being in the blood isn't the goal. It's just the highway. The real destination requires mapping the pharmacological journey from those vascular highways directly into the tissue compartments. Welcome to the Systemic Transit Network, Drug Distribution, and VD. To understand how a drug navigates this complex network, we have to look at the three governing variables of the system. First, the logistics. This represents the speed and physical access your drug has, dictated by blood flow and capillary density. Second, the vehicles and checkpoints, representing how drugs hitch a ride on plasma proteins and the anatomical barriers they have to cross. And finally, the footprint, the mathematical mapping, or volume of distribution, that tells us exactly where the drug ultimately hides and resides within the body. Let's zoom in on our first variable, the logistics. Not all roads in the systemic transit network have the same speed limit. In high perfusion zones, distribution happens rapidly. These are organs with dense capillary networks that receive the highest cardiac output, so the drug arrives almost instantly. But as we move to low perfusion zones, distribution slows to a crawl. However, if a drug is lipophilic, meaning fat-soluble, it will eventually accumulate heavily in this slow-moving adipose tissue over time. But even if your drug is on a high-speed vascular highway, the system isn't immune to traffic jams. But even if your drug is on a high-speed vascular highway, the system is not immune to traffic jams or complete outages. Let's look at 3 pathological roadblocks. First, the pump. In a patient with heart failure, reduced systemic thrust severely delays drug delivery to the tissues. Second, volume loss. Severe dehydration physically shrinks the transit medium, concentrating the drug and dropping perfusion. Finally, blocked routes. If severe atherosclerosis creates a physical wall of plaque, flow to distal extremities is completely shut down. This is a harsh clinical reality. A diabetic patient with an infected toe may experience complete therapeutic failure with IV antibiotics. Why? Because that roadblock prevents the drug from ever reaching the infection. Assuming the vascular highways are clear, the drug eventually needs to take an exit. This brings us to capillary permeability. Not all exits are built the same. In organs like the liver and kidneys, the capillaries have a porous infrastructure. There are large physical gaps in the vessel walls, allowing drugs to easily slip out into the tissue. But if a drug travels up to the central nervous system, it hits a fortified infrastructure. The cells are tightly fused together, and standard molecules will simply bounce right off. But before we talk about how to breach those tight fortresses, we have to talk about how the drug gets there in the first place. We know how drugs exit the system, but how do they actually travel down the highway? They don't always travel alone. Most of the time, they take the bus. This is the transit metaphor of protein binding. In your plasma, you have massive protein vehicles, primarily albumin. When a drug enters the blood, a percentage of it boards this bus and binds to the seats. Here is the golden rule of pharmacology. The drug sitting inside the bus is locked and strictly inactive. It acts as a circulating storage reservoir. It is too big to exit the bloodstream. Only the free, unbound drug running alongside the bus is active and capable of crossing membranes to trigger an effect. This delicate balance between bound and free drug is usually stable. But what happens if 2 drugs fight for the same seats? So, what kind of buses are actually running on these vascular highways? Your body primarily uses 2 distinct transit vehicles. First is albumin. This is your standard transit bus, and it has a high affinity for binding acidic drugs, like phenytoin and warfarin. But if a drug is basic, like lidocaine or tricyclic antidepressants, it won't take the standard bus. It takes the armored truck, alpha-1 acid glycoprotein, or AAG. But remember, these fleets aren't static. If a patient is severely malnourished, suffers burns, or has liver disease, their albumin fleet drastically shrinks. Conversely, if a patient has severe systemic inflammation, their body ramps up production of the AAG armored trucks, and when the size of the fleet changes, the system crashes. We just mentioned that the size of your protein fleet can change. When it does, Or when too many passengers try to board at once, the system crashes. We get a transit crisis. Crisis number 1 is the missing bus or hypoalbuminemia. If a patient lacks albumin, there are fewer seats available. This means a massive, dangerous surge in free active molecules, leading to rapid toxicity. Crisis number 2 is competition. If a patient is stable on warfarin, the drug sits safely on the bus. But if you introduce a highly competitive drug like aspirin, it violently boards the bus and kicks the warfarin out of its seat. Suddenly, the patient is flooded with unbound, active warfarin, dramatically increasing their risk for a massive bleed. You have to monitor who is on the bus. If a free, active drug successfully travels down the highway and wants to enter the brain, it faces the ultimate checkpoint, the blood-brain barrier. This barrier is a tightly woven biological mesh designed to protect the central nervous system from circulating poisons and viruses. Standard molecules cannot pass. To get authorized passenger status, a drug needs one of two things. It must be highly lipophilic or fat-soluble, allowing it to simply dissolve through the lipid walls, or it must use a dedicated structural carrier, acting as a specific key to unlock a specific door. Understanding these two access methods is critical because breaching this vault can be the entire goal of a therapy or the cause of a dangerous side effect. Breaching this vault can happen in two ways: as an intentional therapeutic strategy or as an accidental side effect. First is the intentional bypass. For Parkinson's treatment, we need dopamine in the brain, but dopamine can't cross the barrier. So, we use carbidopa as an escort to unlock a specific carrier transporter, sneaking levodopa inside where it converts to dopamine. Second is the accidental bypass. Take an older antihistamine like diphenhydramine. Due to its highly lipophilic structure, it effortlessly slips through the lipid walls of the brain. This inadvertently depresses the central nervous system, which is why it causes such heavy drowsiness. The brain is heavily guarded, but it isn't the only vital compartment we have to worry about. The brain may be a heavily fortified vault, but what about the barrier protecting a developing fetus? It turns out it's quite different. Unlike the blood-brain barrier, the placental border is just a filter, not an impenetrable wall. While it regulates standard molecular transfer to protect the fetus, it is highly permeable to lipophilic drugs. This leads to severe clinical warnings. Take carbamazepine, a Class D drug. It rapidly crosses this border, accumulating heavily in fetal tissue at 25 to 60% of maternal plasma concentrations. This is why drug distribution matters so much during pregnancy. We've covered the logistics of blood flow and the transit vehicles. This brings us to the third and final governing variable, the apparent volume of distribution, or VD. VD is not a true physiological volume like the size of your liver or heart. It is a theoretical footprint. It represents the relationship between the total amount of drug you administered into the body and the concentration that is actually measurable left behind in the blood plasma. If the drug escapes the blood, it hasn't disappeared. It's just hiding. And to find out exactly how deep it's hiding, we have to look at the mathematics of the footprint. To find out exactly how deep the drug is hiding, we use a simple equation. VD equals the total amount of drug administered divided by the measurable plasma concentration. Think about how fractions work. You inject a constant amount of drug, that's locked. But if that drug quickly escapes the blood and hides in the tissues, your measurable plasma concentration drops. Mathematically, dividing a constant number by a tiny, shrinking denominator forces the result to blow up. A low plasma reading creates a theoretically massive volume of distribution. This is the illusion of dilution. A high VD isn't a massive organ. It's just mathematical proof that the drug is hiding in the tissues. So, what do these footprints actually look like in practice? Because drugs have different chemical structures, they create very different mathematical footprints. This gives us the VD spectrum. On the low end of the spectrum, we have a low VD. These are drugs like gentamicin that are trapped exclusively in the blood. In the middle, we have a medium VD, representing drugs that distribute into the water spaces just outside the cells. But on the extreme high end, we have a high VD. Drugs like chloroquine have such a massive footprint, up to 140 liters per kilogram, because they distribute incredibly deep into vast tissue spaces and fat. But why do some drugs stay in the blood while others vanish into the fat? It comes down to their chemical profile. Why do some drugs stay trapped in the blood while others vanish into the fat? It all comes down to their chemical profile. A low VD profile belongs to drugs that are hydrophilic or water-soluble. They have a large molecular size and a high affinity for binding to plasma proteins. As a result, the drug is anchored in the central compartment and plasma readings are high. Conversely, a high VD profile belongs to drugs that are lipophilic, fat-soluble, with a small molecular size and a high tissue binding affinity. The drug vanishes into tissue, meaning plasma levels will read artificially low. This creates a major clinical problem. If a drug constantly hides deep in the tissues, how do we ever achieve an effective concentration in the blood? We have to saturate the footprint. A low VD drug stays in the vascular space, so it achieves rapid saturation. But high VD drugs distribute deep into the tissues. To achieve an effective plasma concentration rapidly, without waiting days for steady-state accumulation, you cannot use a standard drip. High VD drugs require a massive initial loading dose to saturate those vast tissue spaces first. We can calculate exactly how massive that dose needs to be using the loading dose equation. But you must be careful because a patient's pathology can physically warp their footprint overnight. You can calculate a perfect loading dose on paper, but you must be careful. A patient's pathology can physically warp their anatomical footprint overnight, completely changing how a drug behaves. Take edema or ascites. This increases total body water, creating a massive new hiding space for hydrophilic drugs like beta-lactam antibiotics. This artificially increases their VD, leading to a reduced peak concentration and a prolonged half-life. With obesity, increased fat reservoirs massively increase the VD and half-life of highly lipophilic drugs like diazepam. And finally, aging. As we age, our total body water decreases and baseline body fat increases, physically shifting the expected normal VD for both types of medications. Distribution is a highly dynamic process, so let's put all these variables together and track the life cycle of one drug through the entire systemic transit network. Let's put everything we've learned together. This is the master synthesis, tracking the complete life cycle of a high VD drug. The drug enters Zone 1, riding the high-speed plasma. In Zone 2, it encounters plasma proteins like albumin. While some of the drug gets trapped as passengers, the free fraction continues down the highway. Reaching Zone 3, it hits the heavily guarded blood-brain barrier. Being highly lipophilic, it easily slips through the checkpoint and enters Zone 4, hiding deep within the CNS tissue. The ultimate result of this journey? Because the drugs successfully escape the blood, you get a massively high apparent volume of distribution and remarkably low measurable plasma levels. If you want to master pharmacokinetics, you must remember the 3 unbreakable rules of this systemic network. Rule 1, the passenger rule. Only the free, unbound drug is biologically active. Bound drugs are just a circulating reservoir. Rule 2, the border rule. The BBB strictly requires lipid solubility or a carrier, but the placenta is just a filter. And Rule 3, the footprint rule. VD is the illusion of dilution. A low plasma reading just means the drug is hiding deeply within the tissues. We've survived the stomach. We've navigated the highways, fought for seats on the protein buses, and infiltrated the tissues. The drug has been successfully distributed, but the body doesn't want it there forever. It's time to break it down. In our next video, we are tackling metabolism, going head-to-head with the liver's ultimate dismantling machine, the cytochrome P450 system. Click the video on your screen right now to learn about CYP inducers, inhibitors, and deadly drug interactions. I'll see you there.